And welcome back. Joining me now, world-renowned Dr. Craig Walker. And I can remember once again when he first got started, and he just blossomed, would be a good word. He started doing these conventions, and now he's been in Germany and China, and just all. When you go to Germany, before we get into our discussion, when you go to Germany and China, what are they looking for that's different from a U.S. seminar, or is it all the same?
No, they're not the same. To start with, every country has certain things other countries do not. They want to know things that we have that they don't. They want to know many of the new treatment approaches that we have started, many of which, as I said, started right here in Homa. Right. They want to know how do we do some of those things. They want to learn from that. So each of these conferences is quite a bit different. In China, they're still at a younger stage. Japan is a little bit at a more advanced stage. Right. France and Holland, we've done quite a few conferences over there as well. And so there are different needs across the world.
And the diets are different.
They are, yeah. But there are even different needs. People are trying to figure out how can they take the equipment that they have and achieve better outcomes. And a lot of the things that we started here, since now in today's world, America really doesn't get new products quite as fast as Europe does in today's world. They're very intrigued. How do we achieve very, very low rates of amputation with the tools that we have? And they're very interested.
But are they ready to invest naturally? What you all do at CIS is very costly equipment-wise. I mean, it's just high-tech stuff. Are they ready to make that leap most of the time?
They are. I think they clearly are. This is a big problem. There's an epidemic of peripheral arterial disease around the world, and many people are realizing that this is the key to better outcomes. And, you know, without good health, you really don't have very much at all. But this has now been called, even by the NIH, as an epidemic, a big problem that needs to be addressed. And I think really worldwide, we're starting to see much more attention paid.
And I think we have a slide we're going to pull up. You mentioned the word epidemic, and you know, a lot of people are always a little cautious to use that word, but in this case, you have seen quite a bit of it. There is an epidemic.
We do. Yeah, the risk factors for peripheral arterial disease are much the same as the heart, but a little bit more importance is given to cigarette smoking and diabetes mellitus. Now, there's a very famous lady that does research on, indeed, the incidence of the disease, Mary Yost. She's with a group called the SAGE Group. And this group estimates that right now in the United States, that over 20 million people have leg artery blockages, and that somewhere between 1 and 2.5 million have what is called critical limb ischemia. These are people at incredibly high risk of losing a leg in the short order. And it's estimated that that's going to be at least 2.8 million by the year 2020, and that's only 3 years from now. Now, the reason this is so important is not just the legs. You know, when we talk about leg blockages, people really want to focus on just the leg, but that's wrong. And the reason it's very wrong is if you have lower pressure in your legs than your arms, the pressure in the legs should be the same or slightly higher, because you're just measuring the top number or the systolic blood pressure. And the further you go away from the heart, the higher is the systolic pressure. But it should be the same or higher. And when it is less, and particularly when it's less than 9/10 that in the arms, then you have blocked leg arteries. That's the only thing that can cause that. Now, you may have normal pressures in the legs and still have blocked leg arteries if the arteries are so calcified the blood pressure cuff cannot squeeze them. But if it's low, you have blockage. Now, why is that important? Up to 20% of people who have those blocked arteries will end up having a major cardiovascular event that year. That means either death, heart attack, or stroke. 20%, 1 in 5. This is a big deal. And the reason this is so important, this can be determined by simply checking to see if there are pulses in the feet. If they're absent, it's a problem. And if they're absent, what we can simply do is measure pressures in the feet using blood pressure cuffs and an instrument called the Doppler.
Okay, I'm about to say that I see people, and I use when I put in to check my blood pressure on the arm. That's not the same. Is that the same thing?
It is pretty much the same thing. you have to be able to hear this sound, but much the same. You need a little bit bigger blood cuff for the leg, because it must go 2/3 of the way around the leg to be able to squeeze the artery. But this is a very important test, and it's a very easily done test. It's inexpensive. It is. It gives tremendous diagnostic information, and it's tremendously underutilized. Now, we don't routinely just check everyone, though, Martin, because this would take a lot of effort, a lot of time. So you look for people in whom it would be most likely to occur. And the people in whom it's most likely to occur are people with symptoms, or anyone over the age of 70, just by having reached the age of 70, or anyone over age 50 who has either smoked or had diabetes. Those groups should all be checked. And there really is very little pushback anywhere from the fact that those three groups should be checked. Now, there was a big trial looking at this to determine how common was this. And the trial was called the Partners Trial. And in anyone over the age of 50 who had either had diabetes or had smoked, or over age 70, had an ankle brachial index. An ankle brachial index is measuring the pressure in the legs at the ankle and the pressure in the arms, and then looking at a ratio of those two. And if that was less than 0.9, that was considered significant disease. And as you can see here in the slide, 29% of those patients, 29%, had a decreased ankle brachial index. And when they looked at those 29%, they did coronary angiography, and they found that 44% of them had advanced coronary disease and had no clue. Now, if I can see the next slide, I will show you why this becomes so important. The overwhelming majority of these patients were asymptomatic. So they weren't being diagnosed because they came in saying, I have pains in my legs. Many of them thought they were just old. Many of them had no pains or symptoms at all. They had no clue that they had the disease. It was picked up as an incidental finding. If I can see the next slide.
What were they feeling as with what were they feeling? Just cramps or pain?
Yeah, if you're going to have typical symptoms, the initial symptom is your muscles cramp when you walk, and then it gets better when you rest. That's the most common symptom, but you can't necessarily count on that. And in fact, many people just think they're getting old. They think they have arthritis. Yeah. So if I could see that next slide, because I think this next slide tells it all. Why do we pay attention to this? Well, look, as pressure in our leg falls, as compared to the pressure in our arm, we can see as survival falls. It falls very much. In fact, if I were to go down to where the pressure in the legs is only 4/10 the pressure in the arm, that would give us survival rates as bad as lung cancer. So now if I may see the next slide, if we have a person who's completely without symptoms and has an ankle brachial index of 0.8, that here is called PAD. That has a worse prognosis at 5 years than a woman with a diagnosis of breast cancer, and only slightly better than a person with colon and rectal cancer. And as I said, if we take this all the way out to an ankle brachial index of 0.4 or less, it's as bad as lung cancer. This is a pretty serious disease. Mm-hmm. This is bad stuff.
The research y'all have done on it, y'all didn't have these stats years ago. The research is really proving that what you looked at in the legs was the thing to do back then.
For sure. In fact, we were part of these studies, and it became very obvious as we were part of these studies that these sorts of facts were going to ultimately surface. And that's part of what's good about doing clinical research. Right. We have treatments that we can give long before those treatments are typically approved. But secondly, we're learning the way that things are going to change long before they change. And that's a good place to be. Now, if I can, I'll show you what I call the far end of the spectrum. If I can have the next slide. And I apologize to anyone that this may be offensive to, but I think it's very important. So many people seek nothing and simply get a leg cut off ahead of time. This picture on the left was a real patient that had come in. He had had 7 bypass surgeries on this leg and was told nothing more could be done. And you can see on the right here, we were able to restore flow. He did lose those toes. He did have a skin graft. But this man, for 13 more years, Martin, was able to walk on this leg and not have pain in this leg. He's going on to die, but for 13 years, he was able to save this limb. Now, you can imagine, if we can get to a leg before this, when it's just a tiny ulcer, long before we have infection in the toes, long before we have gangrenous changes of the skin, the prognosis is better, because it's the same basic problem. It's poor blood supply. But once we have infection and wounds, the chance of losing the limb goes up tremendously.
So if people are watching and they have a bad toe, is it more than one toe? Does it start with one toe? What do they look for?
Yeah, it doesn't always start with anything. That's, again, part of the problem. As I told you earlier, I have a patient who's a very thin man, keeps himself in great shape, never smoked, never had diabetes, ran all of the time, and one day he noticed a very small ulcer on the tip of his second left toe. And he kept seeing his physicians in Nashville, and they weren't quite sure. They were thinking maybe he had a pressure sore, other things. They did not measure pressures in his legs. And after about 5 or so visits, he told me they did a pressure measurement and they couldn't record a pressure in his feet. So then they did an angiogram, and the angiogram showed all the vessels below his knee were blocked. Now, he had not had any symptoms before he developed that little tiny ulcer. Some people develop cramps. Some people just feel like they're pooping out quicker. They can't walk like they did before because they're not getting blood supply. But in his case, and some people present with gangrenous changes, but in his case, it was a little digital ulcer. Unfortunately, before I got to him, okay, he had been through 3 different centers. They had tried things. They had failed. By the time he got to me, the whole second toe was gangrenous and infected. But we were able to restore blood flow and achieve saving that limb. And he's doing beautifully well, and pretty excited man. And you'd say, well, this can't happen very often. There are some days where we do 16 or 17 cases like that in a day. It's really very rewarding, because these are amongst the most appreciative patients anywhere. If you look at your leg and you see it infected, you see it hurting every day, and you're thinking you're going to lose it, and then something can be done where in most cases you don't lose anything. But if, for instance, you lose a toe, that's very different than losing a whole leg.
You know, I've heard, used to be, way back when you started, people that came see you, Houma, Thibodeau, Assumption, Raceland, we could go down the line. Now, all over the world coming to Houma. I mean, the ratio of locals to out-of-towners, has it evened out a little bit? Or?
Well, we still see more local people, of course, but when I'm saying local, I'm talking the whole state is local.
Right.
Okay, so to be fair, that's true. But we treat a lot of people from out of state, a lot of people from out of country.
14 now?
Yes, in this state. And then we also have a clinic now in Meridian, Mississippi, and we recently opened up one in Texas. So we've grown quite a bit with this, and these are typically hospitals that have approached us, or groups that have approached us, wanting to work together and really wanting to work with us to learn to do some of these techniques that we've been doing.
Right. Hold that thought. We're going to take a short break, pay a few bills. When we come back, more with Dr. Craig Walker. A very important discussion tonight. This will re-air if you're watching us live at 6 at 9 p.m., so make sure you tune in, or might have a family member who wants to watch. So we'll be right back.